Thank you, Hazel, for doing that. I'm always worried that we forget.
We haven't forgotten yet, so fingers crossed.
Indeed.
And we can give it like 30 more seconds and then get going if that works.
Yeah, we'll start at 12:02. It's 12:01 on my clock.
Yeah, mine too.
I'm going by my computer clock here, but so we'll just wait a couple more, one more minute.
And just so you all know, I will try to do a sort of a closing at 12:55. We'll still stay along here to chat afterwards, but I know some of you guys have another meeting and need to get going, so we do want to give you guys a heads up when it's 12:55. So I don't mean to cut off conversation at that point. It's mostly going to be you can go, and please feel free to, and also stick around if you want to chat some more.
And I see it's 12:02. Should we get started?
Let's kick it off, and welcome everybody. Great to see you all. My name is Dr. John Kelly. Some of you are coming back. Welcome back. Some of you are new. Welcome. Glad you're here. Hope you get something from today's talk. We've got a fantastic panel lined up and a panel discussion on this topic of tele-recovery. Obviously a very vital one and timely one. Just to give you a little bit of background quickly, we are part of this. Dr. Bettina Huppner, who is here in the box here next to me, is the principal investigator along with myself on this project, which is a NIDA-funded project to really stimulate research in the area of recovery community centers. And you can see our fabulous board here, many of whom are joining us today. Next slide. Just to give you a heads up, we are, courtesy of the initiative of Dr. Bettina Huppner, we are doing a national survey of recovery community centers. And so we want everybody, as many centers as possible, to participate. This gives you just a little bit of an indication on the right here of how far we've come and how far we've got to go. We've made a lot of progress. We've been making a lot of calls. So please let people know that we want everybody to participate, because obviously the more people that participate, the better this survey and the information that we get on recovery community centers is going to be, and more value for this very valuable recovery support service, so we can learn more about it. So thanks in advance. Please spread the word. If you haven't done the survey, reach out to us. We'll reach out to you as well. Next slide. So we do a little poll at the beginning of every webinar. Here it is. So please just take a minute, and don't forget to scroll down as well. It's easy to forget to scroll down to the bottom. But if you can just fill out this question, just take a minute to fill out these questions. That would be fantastic. Thank you. Just take a minute to do that. And I will sing a song in the meantime. No, I won't, because it's going to be so good, it'll distract you. So we'll have a moment of silence as you do that.
And once you've scrolled all the way through the questions and answered them, there should be a submit button that you can click. And that's then when you're finally done with it.
Oh, and I also wanted to mention, while we're doing this poll, we do have closed captions. So if you click the CC button, I think you can get captions if you would like that option. We always forget to mention that, but it is there.
Okay. How are we doing there, Hazel?
We have about 50%, so I'll give it maybe 30 more seconds. So if anyone's still working on the poll, you'll have a little more time to finish it. There's some lengthy questions in there, so.
Mhm.
And hopefully there'll be some good information on those questions that we are previewing the content with you.
Okay, so looks like some are still trickling in. Okay, great. So I'll end the poll now and I will share the results. So if you scroll down, and you have to scroll down on your own screen, you should be able to see the results.
So the bottom 3 questions that we had were the questions about the information we'll be talking about today. And it looks like, in terms of familiarity with digital recovery support services, live online mutual help meetings is what most people said that they were familiar with. There was less familiarity with text messaging services or using social media or other technology to deliver peer support services. And then let's see, and then we'd ask about how you actually feel about what these support services, these digital ones, mean. We had most people intrigued and excited, 64%, and only 4% concerned about the complications they cause. And then a good number of us, about 30%, equal parts excited and worried, as there's a lot of new challenges we have to overcome and learn as we do this. And then we also have the biggest barriers that we were thinking about what exist currently to using telerecovery effectively. And the biggest ones that people, or what most people endorsed, was the limitations they pose in connecting emotionally and the limited access to the internet that exists, access to broadband devices, private spaces, and so forth. Each of those was 64% of us said that those are real limitations that we currently face. Great.
Nice summary. Thank you, Bettina. So no further ado, we'll move right along. Thanks for taking the time to do the survey. Every month we feature a different recovery community center so that we can hopefully get some more insights about kind of how these things work, how they look. And today we're blessed to have Dr. Mark Lassiter, who's a board member of Will's Place. So I'll hand it over to you, Mark.
Mark, you're currently muted.
Thank you, Dr. John. I'm Mark Lassiter from North Carolina. I'm a dentist actually in recovery for 19 years, and I've been on the board of Will's Place for about 4 years. We wanted to say, first of all, we're very excited to be a part of this. We are excited to know we're not living in a vacuum here in North Carolina, in rural North Carolina, doing what we do, and that there's so many minds coming together to help us come up with evidence-based treatment options for our patients, so that what we do is working and we know it's working. We're excited to be part of your endeavor. Thank you again. Would like to start this with a video, if you don't mind, to sort of give an overview of Will's Place, and then I'll go from there.
Every 4 minutes.
Let me know if you can hear this, by the way. I know sometimes Zoom.
I can.
You can? Okay, cool.
Yeah.
Great.
In America dies from an overdose or alcohol-related cause. At Will's Place, our mission is to provide people struggling with substance use disorder, those in or seeking recovery, along with their families, the tools, resources, and hope they need to create a different and healthy future. A North Carolina 501c3 nonprofit organization serving the community of Stanley County, Will's Place is the only free resource center in the county focused on holistic care, helping connect you with a detox or rehab center for initial treatment, and then providing follow-up care, such as programming and events centered around recovery, supportive, non-judgmental relationships, peer support, wellness programs, and tools like LifeTrack, smart technology that provides targeted and personalized treatment with data-backed precision to help sustain sobriety. Reach out to us in person, by phone or email, or find us on social media. We're here to help you on the journey to recovery.
Thank you. So yeah, as you can see, we are basically going down a progressive track to using data to support what we're doing. We started out as several years ago in 2017, and were formed based off the death of Will Hudson, who is the founder, Allison's brother, who died of a fentanyl overdose 10 years ago this year. And out of that tragedy grew Will's Place and the concept that we needed to reach out to our community and help. And basically it started with no money in a very small building, and it was a resource center, basically connecting people to whatever resources we had available at the time, which was in large part detox and hopefully some sort of primary treatment. We've grown since then quite significantly to the point where we've created relationships with the local hospitals and the politicians, schools. We're very program driven. Basically our three-pronged approach is to combat stigma, to provide a long-term sobriety, staying in sobriety for long-term successfully, and to basically give access to our people and take down barriers to that care. The biggest barriers, obviously, I mean, from what I can tell, are financial and just people being willing to say they need help. So we have several programs that start as early as basically elementary school level. So we can reach out to elementary school students to have a summer camp. And they basically apply, and if they're affected by addiction or even in the families in recovery, we can start them very young, kind of getting them an insight on what addiction is. We also have a high school program. We have a faith-based leader. We have a twice a month faith-based membership meeting that we have for our participants, and we basically look at the patient as a mind, body, spirit. So we actually have programs that come in from the hospital. Teach about diet. We're looking at mental health concerns. So we're trying to cover all the bases. And a lot of it, I will have to say, is efficacious, but we still don't want to be spitballing this forever. We want data. We want to interact with you guys and, the best minds in the world. We would have never had this option a few years ago, and it's extremely exciting to us. One of the things we're using now is a ground floor technology where we use Oura rings to track certain things like heart rate variability, where we can maybe get some insight on what's happening to people before they relapse, and have interactive kind of ways of keeping them encouraged to stay in recovery. So in terms of data to know what's working and what's not, we don't have a lot of that yet. We're getting ready to start data collections and dashboards to report to our board and to our stakeholders. So we're excited about that as well. Recently, our political support has included a $1.5 million grant from the state of North Carolina Capital and Infrastructure, basically to allow us to build a huge center, something that we can take and create our own ability to have individual centers for people to go in and do telerecovery. We have places where we can do presentations, audiovisual centers, offices for other auxiliary staff and people in the mental health field to come in and help out, training rooms, things like that. So it's amazing that we went from this small center, thanks to the Hudson family and the community, to this. And I will say a lot of us have been affected or are in recovery. And I really think that's important. I was thinking about how I could use my 4 minutes today. And I sort of broke down in tears because my father died of addiction. I have 5 children, 2 of them, one has been in recovery, one needs probably to be in recovery. I know how this affects families over generations. And to have you guys sit here and listen to us in our little recovery community center in Stanley County, North Carolina, and be able to take what you're doing now and explode it into the world and maybe have some really fast impact, visceral impact on people is so exciting to us. And we really thank you for letting us share, let us share our vision and what we're doing. And really our vision is, I think, the same as yours, which is to create a culture in our community in Stanley County, North Carolina, to allow people to feel comfortable coming into recovery, and then also to be guaranteed that what we lead them into is going to work and be sustainable. And I think that's where the science comes in, and that's a good thing. So I thought about it like it's your compassion and love, and it's meeting science and the ability to have predictable evidence-based care. And that's great. So that's it in a nutshell. We're growing. We're down here you know, I don't know what's going to happen. I'm sitting here talking to all you guys. We never thought this would happen. We'd have this opportunity. So it's just exciting, and we're all grateful for you having us involved in this, and we will do our part, I promise. Thank you so much. And if anyone wants to come visit us and share information, feel free to get in touch with me, lassiter.mark@gmail.com. Thank you.
Mark, that was totally awesome. Getting a lot of love in the chat. Thank you for that. It was just beautifully done and concisely done. Passion, compassion, science, those active ingredients that you said, you know, it's so powerful, isn't it? That combination. Let's hope we can, you know, move it forward. And thanks for your collaboration and support of what we're doing as well. We want to support you, and we're grateful for your support. So moving right along to our presenter speakers as well. Now we're going to start with Dr. Rob Ashford, and then we'll move on to Ms. Brenda Max and Ms. Marcy Gray, who you can see here on the screen are 3 panel speakers today. We'll start with Rob. Over to you, Rob.
Thanks, John, Dr. Kelly, and thanks everyone for attending, not only as a presenter today, but also as a member of the advisory committee. Continued attendance this and lifting up different recovery support services research and moving this field forward in places like Will's Place is just phenomenal. So thank y'all for joining. And we're going to take the next 10 minutes to really provide a high-level overview of the topic today. And I'm going to make sure that you can screen share. If you can't, somebody post in the chat for me. But we're really here to talk about digital recovery support services broadly, and also more specifically around Tele-Recovery peer services, or delivering direct peer recovery support through digital means, and those implications for recovery centers. What do we know? What do we not know, which is a lot? And what are some of the practical implications as we continue to move forward? And then hearing some stories from our other presenters. Bit of background about me before we get started. If we haven't met, I am a recovery scientist, and more importantly, I'm a person in recovery myself. That's why I'm in this field. Just disclosures, as you saw before on the previous screen, I am the executive director of an RCO in Philadelphia called Unity Recovery, and also am a partial owner of several digital recovery support companies, including Recovery Link, Boulder Care, WeConnect, and others. And with that, let's get started. So assuming you know everything or nothing in between, it's important to set the context of what do we actually know about this topic. You know, if we look back over the last 2 decades, there's been a substantial body of research that's focused on the use of social network sites, such as Facebook, Twitter, and other private social network sites, such as SoberGrid perhaps, but generally to promote positive behavior change, such as weight loss and physical activity. It's where a lot of the body of research has existed historically. But more recently, we begin to see research coming out around the role of public, these idea of open ecosystem, things like Facebook, these different types of social network sites, and predicting and intervening on risky alcohol use specifically, and to show promise in devising real-time interventions to change those related behaviors for those at risk of developing a future AUD. So much more on the kind of clinical side or JIT side based on acuity, but not so much on the recovery support side, which takes us to those types of digital tools, such as smartphone applications, which have been rising in popularity, text messaging or SMS services, and private or closed ecosystem social network sites really haven't been rigorously studied in examining to reduce the risk of substance use or in promoting long-term recovery. I think one of the facts and reasons we're all here today. And furthermore, the use of very specific digital tools, a subset of this larger category of different digital recovery supports, such as phone and video platforms, Zoom like we're on now, and others, to provide direct one-on-one peer recovery support, otherwise known as recovery coaching, and broadly as a service known as Tele-Recovery, which you've heard a few times today. It's our field's version of telehealth or telepsychiatry, if you will, hasn't been directly examined. But we do know, at least anecdotally, and I think everybody can attest to this, over the last 2 years especially, it's just grown exponentially out of necessity because of the COVID-19 pandemic. So let's get a little more specific. So we do know, at least around the taxonomy, that the different elements of digital recovery support services is named really came from a systematic review that myself, Dr. Kelly, Dr. Bergman, who's also here with us today, and Dr. Brenda Curtis published in early 2020, around looking at what digital recovery support services are, what exists, how are they used, what can we infer based on the research to date, and which more importantly tells us what do we still need to know as we move forward, because we're using this in people's lives on very personal and important healthcare concerns like behavioral health disorders. So based on that paper, we broke down the different types of digital recovery support services that exist. And those can broadly be categorized in recovery-focused websites, websites that give information about recovery, about substance use and mental health disorders and everything in between. Digital recovery forums, which can be things like Reddit, if anybody uses that, that allow people to interact together, not necessarily on a traditional social network site like Facebook, but can have conversations back and forth and kind of threaded replies and conversations that's asynchronous. We also have more traditional social network sites that are recovery focused, both open and closed ecosystems. So public ones like Facebook that may have private groups on that platform for anybody that wants to talk about recovery, but it's a broader audience. And then things like Sober Grid or She Recovers, which can be social network sites that are closed. They really are specifically, the population is those that share an identity of wanting, seeking, or living in recovery at any given time. We then have smartphone applications of a whole different range of categories that are specific to not just existing in the cloud and being accessed from a traditional website, but can actually be downloaded to your phone and used. We have things like recovery date trackers and time in recovery, otherwise known as sobriety link for many people. Things such as Sober Good, which you've mentioned, which is a smartphone app and a social network site, things like HS, et cetera. Then we also have what's largely was used and probably pioneered, at least in our field's perspective, around smoking cessation, but SMS or texting interventions and recovery support services delivered through those engagement channels. But outside of really identifying the types, the categorization, these typologies or phenotypes of digital recovery support services, we found limited overall evidence about the efficacy, the impact, and the role in which they produce positive or any outcomes that were related to recovery. Very limited evidence generally, except for a very specific subset of DRSS that were more common over the last decade. But we also, and I think this is the highlight, and we see some of this for many of you that were excited about the potential of telerecovery and specifically and broadly digital recovery support services to really make a difference in ameliorating barriers related to accessibility, which is an ongoing conversation across the US and really the world, and engagement compared to more traditional in-person recovery support services. So we take all that together, and what's the TLDR of this? How do we define digital recovery support services? And what they are, in a nutshell, is they are recovery support services, a variety of things, whether that's peer services, pro-social support, advocacy, education related to recovery, that are delivered via technological platforms, such as smartphone applications, websites and forums, social network sites, and networking platforms. But it's an important characterization as you think of this and we're doing this work. These are digital recovery support services. We have not yet ventured into the arena of virtual recovery support services. Nobody is putting on an Oculus headset as of yet and engaging in a recovery meeting or engaging with a peer specialist in a true virtual reality or virtual environment. We're still, just as many of you are now, sitting in front of a computer, staring at really a two-dimensional screen and engaging through these types of services digitally, not virtually yet. And the distinction is important so that we can continue to push the field forward so that in 5 years, 10 years, et cetera, we are talking explicitly about virtual recovery support services, which may even have the potential, though we don't know, to ameliorate some of those concerns like you answered in your poll, which is around the connection, whether it's using haptics as well as the virtual reality to really build rapport and feel like you're right next to somebody instead of just staring at them on a computer screen. But it's that difference that allows us to explore both opportunities and be very specific as we grow as a field. And as we move forward, we begin to think around one specific type of telerecovery, which is that almost no research done, but has begun to be identified as a specific type of service. It's this newest entry into available digital recovery support services, or telerecovery. So again, this is traditional one-on-one peer support or group-based peer support through life skills workshops, didactic trainings that may involve many recoveries with a peer specialist or equivalent that are delivered over video, over phone, or messaging, being MMS or SMS. And it may include, and many of you may know this term around telephonic recovery support. It's really the precursor to more fully fledged telerecovery, which is more akin to telehealth. But we really have precursors in our field of recovery checkups, RMCs, telephonic recovery support, or brief check-ins that have been delivered for much longer than we begin to think around the last 2 years or the last 5 years. And as we think of this service, there they're really best supported, just similar to in-person recovery support services, by a HIPAA and Part 2 compliance software solution. And we're beginning to see many of these pop up, two of the most common being Recovery Link or Recovery Data Platform out there that are supporting RCOs and other peer-run organizations to do this work every day. But the reality is the research is just now starting to examine for who, under what conditions, and to what extent telerecovery services are efficacious or not efficacious, or if they're just neutral, they're just similar to in vivo recovery supports. We really don't know. We have to answer these empirical questions, and they're important ones to begin to explore. We think, at least I would say I think, I won't speak for anybody else, that these types of services may allow RCCs or RCOs or other peer-run organizations to increase service capacity more efficiently through the use of automation and digital practice management tools. So not reducing the quality of recovery support offered, the rapport and the peer-to-peer relationship, but allowing us to do that more frequently and for more people without taking away from it. And also has tertiary benefits of providing the recovery support services field broadly, much more insight into outcomes, activities than we've ever had before, and still to today, through what we call health services research or administrative data. The data being collected as services are delivered, and a whole lot more data than in-person services, because everything is, like it or not, is pretty much tracked in a digital environment, even if it's compliant with confidentiality regulations. So what does all that mean, at least from my perspective, as we kind of interpret this? What implications should we be looking at? And we'll look at it from two different perspectives, generally, and then also more explicitly to RCCs and RCOs. So to recap, there's several different of these DRSs out there, at least from the 2020 paper. I would say there's even more now. In that paper, we grouped in digital mutual aid meetings, like all recovery meetings, within recovery websites, because that's largely where they were delivered through, places like in the rooms. But if we were to do that paper again now, the advent of using Zoom and other compliant video software just to deliver meetings, not through a website, has really just blossomed. We are a partnership with 5 RCOs where we've delivered over 6,000 meetings over the last 18 months for over 1.5 million people. And it's just video meetings, all recovery meetings. So those are likely their own typology now if we were to look back, and these continue to grow. What we knew 2 years ago has greatly changed now and will be greatly different in another 2 years, probably. We also know from previous research coming out of RI, from the National Recovery Study, many of the colleagues that have already spoken today are on the video were part of that, but nearly 10% of US adults from the study in 2016 had used some type of digital recovery support services. So a low prevalence generally, but we probably could assume over the last 2 years, this number is much, much higher. We don't know what it is, but we should begin to at least anecdotally think many people that were on the fence or hadn't really ever gave it a shot have over the last 2 years. And this research does suggest, since it's helpful in providing interventions or support, potentially to those with lower substance use severity and assist in preventing progression of the disease. So it's, when we think around recovery supports and who they may best benefit, we may be able to quickly deploy digital recovery support services to intervene even earlier, to get people not indoctrinated, which is the word I was thinking of, but the idea of what recovery could look like well before they have a high acuity or severe progression of disease. Can we intervene earlier and get people engaged in a healthier lifestyle at their own discretion, because it's much easier to engage. Getting on a meeting or another DRSS from my computer is a much lower threshold than actually driving to an RCO. Something we begin to think around of who we're serving and where and how. Digital recovery support services in that vein really may be ideal to expand into really hard to reach areas across the US or across the world. And that could be geographic, so rural and frontier areas that don't have a whole lot of in-person infrastructure or RCCs that exist in a brick and mortar fashion, or communities that are specialized communities, which I'll talk about in a moment. And more importantly, I think generally outside of being easier to expand is its lower cost. Really putting scaffolding and infrastructure in a digital environment is much cheaper than building a whole bunch of new brick and mortar RCCs. Not that we don't need brick and mortar, we absolutely do. We need both of these kind of array of recovery support services. The DRSS may be cheaper, and I think we all could agree that funding for recovery support services needs to greatly increase generally. This could be one way to help more people without that money beating down our doors today. We also know, at least generally, and think that DRSS may assist in reducing these social and environmental barriers to engagement. Things like transportation, especially if you live in rural or non-metropolitan areas without public trans or a good public trans system. Employment schedules, in terms of engaging. I need to work 12 hours a day to support myself, and I can't come in traditional kind of 9 to 9 hours or 9 to 5 hours. And also things like childcare. When we begin to take these things out of the picture, because people can engage on demand from the comfort of wherever they're at, with peers or other recovery support services, those really can begin to potentially to reduce barriers and increase levels of engagement, and thus hopefully improving outcomes over time, because people aren't attriting for environmental and social reasons. And generally, because what we found in the systematic review, these services can be highly specialized for whether it's cultural congruence or specialized populations that are underseen and underserved, often in a variety of contexts. But to create standalone DRSS quickly and cheaply that are for specific communities like Black and Indigenous people of color, LGBTQ+, and others. And if we also look at other bodies of research, specifically in this, and She Recovers is a good example, they actually show generally higher rates of engagement when communities are specialized. So it prevents a unique opportunity to begin to really serve a variety of people in really intentional ways that we may not always be able to do as easily with traditional in-person services. And finally, as we transition to the last piece of looking at what should RCCs consider for themselves, what are those practical implications? Recovery community centers may provide a really useful resource brokerage services, even if they don't provide digital recovery support services directly for a variety of reasons. They can help connect recoveries to traditional in-person support, and then we've seen this happen much more over the last 2 years, and you'll hear about it from our future speakers, of connecting them also to digital recovery support equivalents or replacements or something in conjunction with. And this may help to ease those burden of recoveries, locating DRSS in an ever-expanding set of choices. If you've ever tried to find treatment, which I think is the one we look back on, which is not a recovery support service necessarily, but an entry point, it can be really hard to figure out what's valid, what is ethical, what's a good service for my specific context. And RCCs and RCOs and peers can really help navigate that within this digital recovery support service land, and doing some of that vetting and getting people information at the point they want them as resource brokers, which we do all the time anyway within recovery support services. In the same or similar thought, they may be well positioned to create their own digital recovery support service options, such as digital all recovery meetings, which many of you are doing if you're in RCOs, pro-social activities, et cetera, or to become hybrid RCOs, which I would endorse as Robert, the scientist and RCO director, that can provide both brick and mortar traditional services and digital services. So they're serving their entire milieu in their geographic areas, or expanded from that by offering hybrid options. And I think that's the best approach as we continue to move forward. Leveraging in-house, meaning digital recovery support services offered traditionally by the RCO themselves, may be a viable option to expand impact and reach without the need for expanded or very large sums of money. And this isn't a statement to say, let's not go and continue to advocate for more funding, and that it's necessary. It's part of the reason why we need to do this research within recovery support services broadly. But if we can do this in a low-cost way now, we can really begin to address some of the service deserts across the US until we get to a point where every person in the United States has it on-demand or near on-demand access to recovery support services. We still have a whole lot to do, and digital recovery supports could really be a viable opportunity for that. And finally, I think, and maybe not finally, but there's two more, but RCOs and staff and related, especially leadership, may benefit from investing into staff and recovery technology and hardware, as well as adding advocacy points to their agendas related to universal broadband, making broadband a utility rather than a commodity, which many of you highlighted in the polling. But RCOs and RCCs are great advocacy machines. Peers love to, and so do participants or recoverees and everything in between. And we often advocate specifically around recovery support issues, but we have intersecting issues that are really going to impact our ability to deliver services well. And this is one specifically around making broadband universal that could be really well served for RCOs to continue to add to their agendas year over year. And finally, RCCs may also benefit from adding services related to increasing digital health and technology literacy to their menu of offerings in the future. We're well connected and well placed to educate recoveries around things that they may access. So adding that to service lines, just like you might with health literacy, if you do community healthcare working or traditional peer services, to help recoveries jump over those barriers to being concerned about engaging, not thinking they know how to, et cetera, and should be a core service offering for RCCs as they expand within this digital arena. And if you get the slides, I think references are important. So you'll see the last two have those if you want to do any more reading. I think Hazel and the group is also going to send out some of these papers after the fact. But thank y'all for letting me present. And I am looking forward to hearing from some on the ground RCOs that are doing this work and how they're doing it. But thank you.
Rob, thank you. A lot of applause going on in the chat, and thanks for that lovely overview. We'll move right along over to Miss Brenda Max to introduce herself. Brenda?
Hi, everyone. Thank you so much for having me on to talk about our resource center here and the telehealth. We started actually with just recovery homes, and then I realized something that the recovery needs a lot more to do than just be told to go to meetings and pay your rent. So I did start with a resource center, was one of my first. I started doing in-house classes and education. And then knowing that we couldn't get funds for a resource center to build or purchase, I did it on my own. And I started with just a house and a tent outside, and realized that all of the community and all the public wanted to come and see what we were doing, which was amazing, a 20 by 40 tent filled with individuals in recovery. So now our programs consist of, I recently bought a building. It's 14,000 square feet. So we also have individuals in for not only education, training, we can get them to treatment, we can get them job staffing. We have food pantry, clothing pantry. We have a gym, we have holistic healing, we have wellness and integrated medications. We do, oh my goodness, legal assistant webinars, community service. We also represent, we have peer recovery coaches that will go with individuals to court or on Zoom as it is now with our new telehealth. We also do women's and trauma-informed yoga, men's trauma-informed yoga, AccuDetox. We have family recovery coaching. We have grief and loss, and both grief and loss and our families in recovery have been on Zoom and hybrid for over a year and a half now. As well, we have one high intense yoga that is a hybrid as well. We do vocational training with computers, art. We have woodworking classes. We do mechanic classes and training. So there's a wide variety of what I try to put in with all of the recoveries that come into our building, even in the community. As well, we have a serious mental illness grant that we work with individuals during the day. 3 days a week. And so we have a certified therapist, counselor, a pastor. We have a licensed social worker on staff. And all of this started by just reaching out, getting grants, getting help from the community and letting them know what we do here. I know we are here to talk about the digital recovery. When COVID did hit, I made sure that my homes, which I had over 100 clients, were doing Zoom meetings so that I could see them all in their homes, that everybody was doing some recovery. We would do some art in the homes because at one point in time, we couldn't even leave. So it was a little chaotic and crazy, especially to try to tell somebody that needs that connection and that contact with other individuals. Guess what? Your whole world just changed. Now you just have the individuals in your house without arguing and fighting, with 15 other people. This is what we're going to do today. So we also learned at that time that there was more meetings, more connections, more places to be online. So we would ask them to attend meetings for more per week or more if they needed. And so our IT tech guy was doing Zoom receipts. So if they registered, we get a receipt showing that they did attend these meetings, which worked out perfect for us to produce to their probation, court, and or any type of grant that we had. We were providing documentation. Through our website, we would collect the data. How many individuals were attending these meetings? So, we're working to continue that as well, and we recently received a telehealth grant where we are going to start helping individuals in Macomb County area to, by the way, we're in Michigan. So in the Macomb County area to connect and be able to come in, we will show them how to get connected, set them in a separate room in the building and let them do their telehealth. And at the same time, we will have a peer recovery coach here that can help them afterwards. If it's an emotional, if they need some extra support, we do that with the SMI teams for AOT, that's assisted outpatient treatment supportive services. So we help the individual when they are done with their meeting, or we can we can sit in with them if they're okay with it and they give us permission, which usually they do, so that they remember to talk to ask questions to the judge or their therapist or whomever the meeting is with. So we're learning a lot of who needs extra support. And, some individuals that may have had longer clean time or been in the fellowship or programming before, they may not need as much support after a meeting or a session. We're learning what it works and what doesn't work. I believe I answered everything here. If we could go to the next slide. So again, we're talking about the virtual meetings. It's fun to see that, like in the yoga, some people don't want to come in, and some people like to be at home doing their yoga, and that's great, and then some people still have this fear of even wearing a mask. They don't want to be around other individuals. So that leads me to think that some introverts would get more comfortable being on a Zoom meeting, being home and not leaving their home. For the recovery and the recovery era that I started my recovery in, we were always taught to be at a meeting when your feet and your hands are on the table and you're sitting there, you're connected. And it's kind of a relief. And I don't know how many other people in recovery go to a meeting and they can leave and they feel relief. Sometimes being on a telephone or on a website, you may not get that connection. So that would be like one of my main concerns, is that they need to be connected still. So I like what Dr. Ashford was talking about, the virtual. So when that comes out, I would love to try that too. That sounds amazing. But for right now, what we're focusing on is helping that individual, whatever they need, and if they need to be in person, and if they need to be on Zoom, help that individual be here and handle whatever services we can for them. We have a wide variety of services here at the Resource Center because I believe everybody needs support. And I believe that you can't just send the individual down the road. Yeah, you can go down here and get a job, or you can go over here and get your therapy, because when you send them down the road, do they do it? Not always. Will they make it there? Not always. They may go the opposite way and end up, in not so good area and maybe dead. So after the virtual meetings, we do try to have some contact. We've had issues where people have just, thrown the meeting to the curb. So I've spoke with other therapists and asked them, what do you think when you're talking with an individual, on Zoom, and how do you feel? Can you read their vibe? Can you see everything about them when you're talking with them? Do you know where they're at? And they sometimes say, well, no, if they hang up on me, I just note that in my file. How is that, from my point of view, how is that helping that individual right then and there that may be in crisis? There's still a lot to figure out. So, having the counselors and the peer recovery coaches with us really does help, having somebody on site, or maybe picking up that phone and calling back, or trying to get a hold of them. But that doesn't always work either, because I know when I'm done, I'm done. I don't have to pick that phone up, right? You can just hit a little tab that says disconnect, even on a meeting. I believe that's all I have here. Thank you. So this was my ask, is that, you know, there is a necessity for a person in recovery that we still need that contact. You still need to be held accountable. You know, in my recovery homes and the resource center, I make sure that all the individuals show up at the resource center once a week, and we all talk, and they're held accountable. They'll say, oh, I have to work. Well, I say this: if you can't show up, you may not have that job, right? You need to show up for your meetings. You need to show up and be held accountable. A lot of times they say, oh, she's like a sergeant at arms. Somebody has to hold us accountable here. You know, it's how I made it where I am today. And I appreciate everyone having me here. I'm going to put our website in there. I realized that I did not have time to add more to the slides, but I really appreciate you having me. And thank you so much. That's all I have.
Brenda, we appreciate you. Thank you so much. That was a beautiful insight into, as you said, still a lot to learn, but you're learning as you go and developing this model. Thank you for that insight and overview. And I'll pass right along to Miss Marcy Gray to introduce herself for the final segment. Marcy?
Hi, everybody. Thanks for having me. I feel honored to be able to present this today. I work with Utah Support Advocates for Recovery Awareness. We have several locations throughout the state of Utah. And when COVID hit, I was very, very unfamiliar with any type of digital platform, but we were pretty much forced to do something in order to continue providing services. A lot of the good things that have come is that we've been able to continue implementing the peer coaching services. So our coaches throughout the state have found to be true that oftentimes people are more willing to engage through a virtual or a digital Zoom meeting, GoToMeeting, Facebook Messenger, one of those avenues. They'll engage better than just stopping by the center. You know, we meet someone, and once we've seen them in person and we get that like warm handoff or whatever, a lot of times they don't come back. They don't have that courage to step through the doors of the center. And so meeting them online first has been super helpful for a lot of the participants that we have down here. A lot of our online support groups or support groups in general, like once we made them a hybrid option, the attendance just skyrocketed. So we've had, especially in some of our smaller areas, a lot of engagement with the online support meetings. And so we do a hybrid option where they'll just set up a computer in the room, and there's some people in person, and then there's some people attending online, and it seems to be working really well. Last year, we were able to implement what we were calling the Recovery Leadership Initiative, where we were doing a class once a month. And our attendance in the beginning, when we were holding it in person, we had like maybe 10, 12 people attending. And then when we moved it to the virtual option, we were getting in upwards of 50 to 60 people attending. And so that was very positive feedback for us. There were people who were willing to attend these classes online, but they were not necessarily wanting to come into the center to attend them. So like I said, we use a variety of different platforms, from Zoom, GoToMeetings, Facebook Messenger. All of these platforms have allowed us also as a staff at USARA to connect virtually once a week to hold a staff meeting, where before, you know, each individual staff at each RCC throughout Utah would have their own little staff meetings, and then we'd get together maybe once a quarter as an entire staff of USARA. So that's been a great thing because we're much more connected as a staff throughout the state. We have a resource list for digital support tools. Some of those are like one of the popular ones is the 12-step toolkit. One of the mindfulness ones that is very popular is Headspace. The Recovery Today magazine. It's like a magazine of hope. Like that one is a good app. Quitzilla. I don't know if all of you have heard of that, but Quitzilla is a good one that's very popular. It's a recovery app to help build good habits. And then there's also, I mean, I have a whole list of them, but these are just a few of them. The Strides it's called Strides. It tracks accountability and goals. And so being able to implement some of those tools during a recovery coaching session, whether it is in person or online, has really been beneficial. I think that some of the drawbacks that we've seen have definitely been, just missing that human connection. But like I said, our coaches are meeting with a participant 1 or 2 times, and then they're wanting to meet in person. So I think it's just still kind of a mixed bag throughout our organization. You could just go to the next slide, Hazel. We've also found that we definitely are able to reach a larger portion of the recovery community. We have a lot of, like every state does, but we have several rural areas that we're really trying to provide some peer recovery support services in. USARA piloted a program at the University of Utah in Salt Lake City, where we go into hospitals and meet with people who are at risk of overdose or have recently overdosed. That is called our ARCHES program, the Addiction Recovery Coaching in Healthcare and Emergency Settings. Being able to do that in my location, I'm in a little more urban area than, so it's a little bit smaller area, but we're also focusing on 5 different counties with small hospitals. And so being able to implement that, either TeleRecovery or, like an online platform to meet with these people so that we don't have to travel to these further distances, has been super beneficial also. And then there's also people who are really struggling with transportation. They're not able to actually come into the center, but we are able to still provide services for them. And we provide a broad range of recovery support services, but like just some of the rural areas that we're currently working in, being able to meet with those people and provide them with a digital platform. If that means that they need to go to the library and just, sit at a faraway computer and visit. So we've been really trying to be very resourceful with how we can help people link up to providing or receiving these services. It really, like the slide says, it's improved some of the functioning in some of the smaller centers that we have, which would be considered more rural areas. And some of the numbers are just going up, which has been a really great benefit. I just lost my train of thought, so I had something to say and I don't remember what it was. But at our larger center, there has been a big drop in attendance because that was in the city, and the attendance of in-person services dropped because they had walk-in hours where people could just walk in and receive services from a peer coach. So that it has dropped there. I think that maybe it has increased here in the smaller centers, the 3 centers that I manage. We've had a little bit more engagement due to the online availability. So I think that really it's just about shifting, as a whole in the way that we support recovery, that we provide peer support services. There's just a shift happening. Well, it has happened and it's going to continue to be this shift. And I think that being able to reach a broader community has really been impactful at our particular center. The digital services have been especially helpful, like I said, for the smaller centers. The hours have been limited more, but by and large, the services that we've been able to offer have really increased the availability of support services. Is there another slide, Hazel? Yeah, as far as what we would ask is more training opportunities. A lot of people are not as familiar with online platforms. Of course, we do some internal training, but then we do run into the occasional person who's not able to, locate a cell phone or have a cell phone, doesn't have computer access. We do have a computer that's accessible to any of our participants. They can come into the center if they have telerecovery appointments with a therapist or a group. They are more than welcome to come in and utilize the computers that we have at the center. And yeah, I think that increased training and service delivery is part of what we would be looking for. As far as the whole digital recovery support services, it's been positive and a little negatives for us. So thank you for allowing me to be here and present. Appreciate it.
Marcy, thank you. That was just terrific. Thanks for joining us and for contributing so meaningfully. We only have a few minutes left, but I know Dr. Bettina Huppner has a few final comments before we can let people go. We will stick around, as Bettina said, for those who can stick around after one. We often have a chat for 10 or 15 minutes if people want to stick around. But Bettina, I'll hand over to you.
Great, thank you, John. And thank you so much, Mark, Robert, Brenda, and Marcy, for sharing your insight and your passion and your wisdom with us. This has been great. We are honored that you took the time to do this for us. I just wanted to sum up for us that we have had only a few people prior to the pandemic really getting a chance to figure out what digital recovery support services are and use them. That was 10% a few years ago. And now all by necessity, we have been gaining familiarity with it, which has opened the door to so many more opportunities. And when Robert talked, he talked about a lot of different resources that exist, and there were some questions in the chat about what's the effectiveness? Do we know how well these things work? Where is that science? And Robert can probably elaborate on this a little bit more if he wants to. I think right now it's still very new. We don't have that data yet. This is what we're still gathering. And alongside that is best practices, how best to leverage these things. As we're all exploring this new territory, we still have to figure out how to make it work in the best possible way. And I think it was wonderful that you guys pointed out the infrastructure support that is needed around staff training and hardware just availability, getting people devices that they can use and in spaces they can use it. So there's a lot of promise here and a lot of unanswered questions. And we are just very grateful that you guys are here with us to start answering some of these questions and gain knowledge in this area. Thank you all so much for being here with us.
Wonderful, Bettina. Thank you for those nice remarks. Any questions? We've got 1 or 2 minutes left. If people have a question, comment for the speakers or anything they'd like to discuss.
So I will say there were some questions about if technology itself isn't addicting. Robert, that was posed during your slides that people were talking about, and then effectiveness. Do you agree with me that that is still very early literature and we don't have a lot of guidance? So in other health behaviors, we know things like text messaging works, for example, for smoking cessation. Smartphone apps work for smoking cessation. Recovery, of course, is much longer and has much more complications, and we don't have that science yet.
Yeah, and I think it's largely true. I mean, I won't say all because I am not an encyclopedia, I know every study ever published, but what I perceive to be most of the published research that we're aware of is really cross-sectional and correlation in nature. And we know about specific types of DRSS, who tends to engage, what they perceive as benefit, but it's extrapolating that to any other population in great ways, having causal relationships, knowing things like efficacy for anybody else other than who was in the study is really premature. I mean, we need a whole lot more research of rigorous design and methodology to begin to answer some of those questions. But I would say we can infer that it's at least promising for those that it might work for and those that will engage, but we just don't know who those people might be and in what ways we can produce really positive outcomes. And I think to the first question, it's important, right? I think these concerns as we build this field together in the interventions, we have to answer questions or ask questions at least of, is there unintended risks like technology use disorders or internet addiction, et cetera, as it's otherwise known? And we don't know. I think Brandon had a really good answer in the chat that's the question we need to ask, right? What are the unintended harms? And unfortunately, we don't know. I mean, there's a lot of research out of Asian countries around internet addiction specifically. I think we can infer some stuff from that, but how it may intersect with behavioral health disorders that are more common in mental health and substance use, unknown. But if anybody's a burgeoning scientist out there in the chat or a person in recovery that wants to be on a research team, ask those questions. Let's get some answers. Let's do it together.
Awesome. And I see that Laurie has a question. Go ahead, Laurie.
Hi, thanks everybody for your presentations. I'm curious, has this been piloted or utilized in prisons, jails, and in those atmospheres where barriers and living a lifestyle of recovery can be challenging.
I'm happy to kick it off and hopefully some of our practical ones. So as it relates to, I'll broadly call them forensic peer services, we work with some RCOs that have gotten permission from the different facets of the criminal justice system in the US to do telerecovery over encrypted Zoom. But they have been few and far between. More often the roadblocks to even like piloting it is that there's no mechanism to even do video or telephonic recovery support because the jails and the prisons aren't allowing it, at least for the RCOs that have relationships there. So I'm not aware of any research pilots in it, but there are certainly individuals providing the types of service in a practice-based setting that may have data on it that can be analyzed administratively to answer some questions. But the major blocker here to me is not the lack of technology. It's the way the criminal justice system is set up and how hard it can be to do research with those that are incarcerated or previously incarcerated, returning citizens, and what's allowed between IRBs, technology in prisons and jails, et cetera. So it's a great question. I don't think if we have little data on the broader sense, we probably have even less on that specific domain.
Wonderful.
Thank you.
Kwame, go ahead with your question.
Before we do, maybe we should say thank you to everybody. We've reached the end of our time, and we just want to make sure we get a big thank you into our panel, and also to Hazel Simpson for coordinating this as always, and Bettina for doing such a fantastic job with all of this every month that we do it. And thanks everybody for coming. I know people have to go. Thank you. Join us next time. For those who want to stick around. Some of us will be here to answer questions, and we can carry on. Thank you.
Thanks, everybody.
And
Kwame, did you have a
sorry if I
question?
mispronouncing your name. Kwame Sunhorse, you want to go ahead with your question?
Yes, and excellent program. And what I'm really concerned with is I've been in recovery now for the past 40 years. And AA and NA started 1930, 1960, or late 50s. And now we're looking at the pandemic and we're looking at recovery by technology. We have a program that is based on spirituality, and now we have to go to techno-spiritual. And the Brenda was speaking in the interaction of energy that's in a room when people are recovering and energy on a screen playing Hollywood Squares on Zoom. It's kind of seeing we're at the gist of this, but the part of it is that I always share is that I didn't get addicted by technology. I got addicted by being in the streets, and I got addicted by interacting with people. And people need people. And so these are the challenges that I see with this techno-spiritual tool, but it's still in the infant stage because this is just 3 years into this pandemic and meetings have had to change and become virtual because I work with White Bison out of Carla Doncoy.
I think there might be some technical difficulties, unfortunately, but.
Oh yeah, it looks like power loss.
Mhm.
I mean, I do want to say, right, so notwithstanding some of the commentary around a very serious pandemic, that the larger context is different strokes for different folks, right? We've been doing digital recovery meetings and initiating recovery for the last 2.5 years for people across the US, that their entryway and their ongoing support is fully digital, right? So I think there's some merit, and choice is always a good thing, but we can't discount what I would imagine is thousands, if not tens of thousands of people now that their first meeting was video. Their ongoing meetings and working with a sponsor, if they're in a 12-step program, or a peer if engaged with an RCC, is over video and phone. And for those people, their recovery is very real, right? And we've got to be careful, I think, not to discount those experiences and begin to embrace choice, just like we do in multiple pathways of recovery. And I think we've got to stay true to our roots in the recovery support services field to really hone in on that, regardless if it's new or different. Because a lot of people say the same thing about harm reduction and medication, and all of those save lives every day.
Mhm. I'm also very intrigued by these kind of hybrid models that Brenda and Marcy talked about, right? Where you oftentimes meet over Zoom, but then also come in person. Because there is something about being in the same room with people and with sharing that energy, with seeing each other, that is very powerful. Like you say, Robert, and I think it was brought up earlier about being an introvert, and then maybe that isn't the best thing for you, but for others, it really is a powerful thing to be in the presence of each other and to support each other in that very physical present sense. So there's so many questions about best practices and what's best for whom.
I just wanted to say that I think it's important that we are meeting people where they're at. And at this, well, that's what we try to do with our RCC, and a lot of people really do want that in-person connection. But at the same time, there's other people who are just not there yet, but they're getting connection just by attending the meeting online. And then it really kind of propels them into being more willing to be seen in person or be with other people. So, I see that as a huge benefit too.